us, and I've seen that we have somebody from South Africa. Maybe somebody can just say something from India. Simran, do you want to say a word?
Hi everyone, so my name is Simran and I work at Ecom. To meet you all. Have a great session. Over to you, Dr. Swadar.
Thank you very much. But you can see the agenda on the screen. We have two erudite lecturers and specialists in this area to talk to us today. First, we are having the Nigerian Center for Disease Control, coordinator of antimicrobial resistance and infection prevention and control. And I'm sure she's well known to all of us. She's also the chairman of the Nigerian Antimicrobial Resistance Coordinating Council. Dr. Tochi Okwor, she's taking the first topic, which is Outbreak Preparedness, National Disease Surveillance Overview. She will give us a national disease overview. But I want to apologize. She may not be able to do it directly. If there are questions, we will send it to her by email, or she has sent us a recorded presentation PowerPoint that we're going to share and listen to carefully. And then subsequently after that, we have the Healthcare Associated Infection Surveillance, another specialist, health facility monitoring and evaluation. That is at the service delivery level, and that will be taken by Dr. Chioma Ejekam. When she finishes, we are going to have one of our own, one of the graduates from the College of Medicine Center for Infection Control and Patient Safety, Dr. Onyekachi Ugwa, to present to us the improvements in the Ipc practices at the University of Nigeria Teaching Hospital, Enugu. And when he finishes, we will note all our questions. Then we'll have discussions for another 15-20 minutes, and then we'll give our feedback and have announcements and prepare for next month. So that's it in a nutshell. But before we start, I want to just quickly introduce, although I've said it already, Dr. Tochi Okwor. She's in between time zones. She's traveling between Canada and US. But she has sent in a presentation. People, can you please upload it? And we're going to play it, but we should listen carefully. She may not be available to take questions, but we have Dr. Chioma Ejekam, or anyone that we can handle, we'll send to her by email, and I can promise you she will respond to them. But I want us to listen attentively to the anchor person at Nigeria's CDC, talk to us about outbreak preparedness, the national outlook, Dr. Tochi Okwor. So, our presentation.
Good day. I'd like to thank the organizers for inviting me to speak on outbreak preparedness, including surveillance. And I've specifically decided to label it Infection Prevention and Control Outbreak Preparedness, because I believe I'm speaking to an audience that is largely infection prevention and control practitioners. I'll start off by just providing a quick definition of what we mean by an outbreak. An outbreak is when we have a group of cases that are linked by both time and place. And often, these diseases are usually suspected to come from a common source of infection. And what you notice is that they're often greater than what is expected to be the incidence of such infection when we compare it with the usual background rate for that particular area, which could be a health facility, a ward, a state, a country, a region, or in the case of a pandemic, global. And there are times when a single case of a certain epidemic-prone disease is considered an outbreak. For instance, a single case of Marburg virus disease is considered an epidemic. A single case of Ebola virus disease is considered an epidemic. One thing is clear: the risk of new health emergencies have continued to increase. And some of the factors responsible for this are factors such as the escalating climate crisis. We know about the global warming, we know about desertification and all that. There's also the environmental degradation. We have an increasing geopolitical instability, and disproportionately, these things impact the poor and the most vulnerable. We also have humanitarian crisis that has been estimated to have affected about 300 million people in 2022. And what this has done, it has put these people at an increased risk of these health emergencies that we know that inevitably follow humanitarian crisis. I project here this figure that is from a recent WHO publication, where it shows the scale of health emergencies from all hazards. And we can see how vast and widespread these things are. And this is just for 2021 and 2022. It's spread all over the world. And we have already discussed the factors that are responsible for this increasing occurrence, both in frequency and in spread, of these often emerging and re-emerging infectious diseases. Because we are infection prevention and control professionals, and recently we are beginning to realize the value and utility and the critical role that infection prevention and control plays in outbreak response. WHO has come up with this document that is the framework and toolkit for infection prevention and control in outbreak preparedness, readiness, and response at the national level. In this document, WHO identifies 3 critical emergency management phases. There's the phase 1, which is the preparedness phase, phase 2, that is the readiness phase, and phase 3, that is the response phase. I'll briefly outline now what should happen in these 3 phases, and then I'll move on to discuss the preparedness phase, which is the main topic of our discussion. I'll then discuss the preparedness phase in more detail. In phase 1, which is the preparedness phase, it is during this phase that we ensure that we make adequate public health emergency response plans for the relevant hazards. During this phase, we map all the potential hazards, we map all the hazard sites, all the potential hazard sites, and we also identify the available resources. It is also during this phase that we develop the appropriate national stockpiles of resources and ensure that I have worked on the capacity to support operations at the intermediate and community levels, and also primary response levels during a public health emergency. So for this phase, sometimes it takes between 6 months to 2 years in order to be fully prepared for an emerging infectious disease or a public health threat. So what this means really is that as we continue to do a constant risk assessment for the public health emergencies that we're exposed to, as we continue to do those risk assessments, is something that needs to start now, immediately, before even that threat becomes reality. We then have the readiness phase, and this is the phase that links an effective preparedness phase and links it to an efficient response phase. And this can take up to 6 months in order to ensure readiness for a specific defined threat. I'll give an example of Lassa fever in Nigeria. We know the times in Nigeria where we begin to have rising cases of Lassa fever. So it presupposes then that this readiness phase should start 6 months to when we expect the rising cases of Lassa fever. And then we get to the third phase, which is the response phase. And this is the stage in which emergency actions exceed the usual levels of activity in response to a defined public health threat. So this is when the outbreak is now occurring and we are then responding. All these, if you look at it in this framework, we can see that it is a flexible framework. And one thing that is important is that they're all linked and there's a feedback loop. One phase feeds into the other. And often we can find out that we already will start with one phase because we may already be in an outbreak when we look at the preparedness phase, we realize that we are in different levels of preparedness. But the most important thing is that it is flexible and it can be adapted to fit the local context. I'll now go into more details on the preparedness phase, because that is the main topic of our discussion today. I've mentioned earlier that this preparedness phase would usually take about 6 to 2 years to be done fully and effectively. And for infection prevention and control, these activities that we carry out during the preparedness phase are to ensure that baseline infection prevention and control activities are adequate in the event of any future communicable disease threats. And what we aim to do in this preparedness phase is to achieve the IPC minimum requirements. And while achieving these IPC minimum requirements, to also continue to work towards a robust and comprehensive IPC program in line with the WHO core components. Because this is what we know will sustain any outbreak response efforts and make us to have good results. So what do we mean when we talk about the infection prevention and control minimum requirements? The infection prevention and control minimum requirements are those IPC standards that should be in place at the national, subnational, and facility level in order to provide the minimum protection and safety to patients, health workers, and visitors. And this is based on the WHO core components for IPC programs. Trying to change the slide. So I have mentioned earlier that in the preparedness phase, we aim to achieve the IPC minimum requirements. So how does this look like? How do we prepare during the preparedness phase to achieve these minimum requirements? At the national level, a good starting point will be to carry out a national infection prevention and control assessment using a WHO tool, the IPCAT tool. And what this does is that during this preparedness phase, it helps us to determine whether the IPC measures necessary are in place at the national level. And we can also use this IPCAT tool. For instance, in our own situation in Nigeria, we use it to also assess the same for state IPC programs. Then these national or sub-national IPC programs should then coordinate and promote the use of the Infection Prevention and Control Assessment Framework at health facility levels. Other assessments that should be done to identify key issues that require attention are assessments on hand hygiene, assessments on the status of water, sanitation, and hygiene, because these things are all very critical that we address them during the preparedness phase if we are going to respond when the time comes. And all these things will then come together and will be used to develop an action plan to serve in the event of a response. So an example here is a report of an assessment that we conducted in 2018 as part of preparedness efforts for Lassa fever. So we assessed 3 health facilities in Nigeria that are located in Lassa fever high burden states in Nigeria. In this assessment, we conducted both the IPCAF for the entire health facility, and then we did the specific infection prevention and control assessments to see how prepared the treatment centers attached to these health facilities were to serve as Lassa fever treatment centers. These assessments will involve site visits, the use of survey forms, the visiting of locations to ensure that not only are the human resources there, the built environments is there, the people are trained, the adequate manpower is there, and you've checked things even down to, as you can see here, where we are looking at the ability to constitute the right concentration of chlorine and checking the level of free chlorine. So it is to that detail that you do your preparedness activities. Having done the assessments, you want to then look at the areas that need strengthening, both at the national level and at the sub-national level, including at the level of the health facilities. So we identify the areas in the IPC minimum requirements that need strengthening. We then ensure that the program's objectives, functions, and activities are clearly outlined. And here by program, we mean our national IPC program, our sub-national in Nigeria, that will be our state-level IPC program, and also that health facility IPC programs are clearly outlined. And that these IPC programs also have an outbreak management component. We then ensure that the outbreak management component also has clearly defined goals and objectives. It is not enough to make a plan. This plan should be supported by a dedicated budget, and this budget should be made available, and there should be provision for outbreak functions such as the additional surge staff that might be required during outbreaks, the staff you need for site visits, and all those things you need to do both at the preparedness phase, the readiness phase, and plans on how to deploy these resources during the response phase. And also something that is important that's done is to ensure that the outbreak management component of the IPC program involves the relevant programs. You may have to involve the environmental health programs. You may have to involve all the relevant programs depending on the outbreak you're anticipating. So often you may have to have and encourage that as much as possible, it also has a One Health approach to these things, because sometimes you also have to do rodent control, you need to work on the environment and all that. So it has to be as comprehensive as possible. An example here, this picture is a picture of an assessment visit we carried out as part of preparedness in our Lassa fever control program. And why I'm showing this is to see how much we can achieve if we have enough time during preparedness phase. So at the preparedness phase, we had visited this facility, and what you see on the left is a tent that they were using for screening and triaging for suspected Lassa fever patients. But following the visit, the site assessments, we found that wasn't adequate with respect to infection prevention and control. And because we had enough time, because it was enough time during the preparedness phase, we had made the recommendation that wasn't adequate. And the result is the improvement you see on the left, the brick building that then took into consideration patient flow and all the other IPC considerations for isolating suspected Lassa fever cases and also for screening and triaging. Like I said, everything will then feed into our preparedness plan. So we'll develop, or where it already exists, we'll reinforce the IPC components of a national or sub-national outbreak preparedness plan. And this was the situation for us in Nigeria during the COVID pandemic. Very early in 2020, we quickly made IPC input into the national preparedness plan. But that was really during the response. So ideally, for those diseases you're anticipating based on your risk assessment, hazard assessment, there should be a proper preparedness plan. And then within this plan, there should be an overall IPC goal and objectives, followed by standard operating procedures or work plans for the following. There has to be standard operating procedures and plans on how to rapidly identify and isolate suspected cases, including cases among healthcare workers. There has to be plans on how to safely collect, process, including transportation of samples to the lab, and how to ensure that these lab results come out on time, because it is when these lab results come out on time that we're able to confirm suspected cases and confirm that these suspected cases are real cases. And this is also what will help us to initiate rapid contact tracing both in community and in healthcare settings in order to identify and manage contacts. And sometimes these contacts are also healthcare contacts. Part of what we also do and reflect in the National Preparedness Plan is that we assess our needs for personal protective equipment and other IPC supplies. Because part of what happens during outbreak is that you have an increased need of infection prevention and control supplies and personal protective equipment supplies. So it is a preparedness phase that will develop the contingency plans. It is also at preparedness phase that we anticipate supply shortages and make plans for them. We're all aware of what happened early in the COVID pandemic, where the world ran short of personal protective equipment. But in a situation where we are better prepared, we should be able to anticipate these shortages and have plans in place to ensure that we reduce the impact of such anticipated supply shortages. It is also during the IPC, during the preparedness phase and in the preparedness plan that we clearly indicate what a coordination will be for the IPC national command structure. It is during the preparedness phase that we identify all the stakeholders that will be required to mount an effective response. It is during the preparedness phase that we identify roles and responsibilities of the ministries and other stakeholders. And this is important because we want to avoid duplication of efforts. Resources are limited, including human resource. So we have to make sure that things are coordinated in such a way that you don't have different ministries, departments, and agencies or stakeholders doing things without coordination. But if you're not well prepared, if attention is not paid to this during the preparedness phase, it's difficult to coordinate this when you have an actual outbreak in your hands. And it's also at this phase also that we develop drills, simulations, tabletop exercises to test our national IPC outbreak plan. It is also during this phase that we develop plans on how to calculate things like PPE stockpiles, burn rates. I've mentioned also the issue of budgets. So here is an example of our national coordination for our Lassa fever emergency operations center. So you can see here that IPC is properly represented, and within this IPC pillar we have the terms of reference and ways of operating, including standard operating procedures, the organizational structure for that pillar. All these things are activities that are done during the outbreak phase, during the preparedness phase. It is also during the preparedness phase that we develop the IPC guidelines, which are very, very important. This should be evidence-based, should be approved, and we should also develop a system to monitor adherence to these guidelines and recommendations. Here's an example of our national IPC guidelines. We have the national guideline for infection prevention and control for viral hemorrhagic fever, and also here you can see our national manual of infection prevention and control. I've mentioned the checklists and standard operating procedures. These become very, very handy. If you develop them well ahead of time during the preparedness phase, then health workers and those who need to act during response phase have these things in place and ready, and they would have been trained. And that leads me into our national IPC training program. In order to be properly prepared, there has to be IPC professionals who by themselves are able to run IPC programs, manage IPC programs at national level, at state level, and also at health facility level. They also should possess the training skills to train frontline health workers on infection prevention and control. And if the need arises, they should also have the capacity to train rapid response teams in response for future outbreaks. And there should be a clear IPC curriculum that includes outbreak management. So what we have here is that the effort we had made in Nigeria in developing a training program for IPC specialists in Nigeria. What you see, the area here circled in red, shows the history of that. It was really as a result of the Ebola outbreak in 2014 that led to the clear understanding that we lacked IPC professionals who will be able to prepare for potential outbreaks and manage it when the need arises. And that was what resulted in the development of a national IPC program. And since 2017 till date, it has been graduating IPC professionals. Now, I'll quickly move into the national IPC program and reporting, surveillance and reporting. This is also part of preparedness for outbreaks. We know that what gets measured gets done. Surveillance helps us to keep track of things, collate them, check them, and see what is going up and what is coming down. So surveillance and reporting of infections, especially among hospitalized patients and health workers, is important in guiding appropriate IPC activities. So a national surveillance program is crucial for the early detection of some of the outbreaks, in which cases are described by the identification of the pathogen concerned. So surveillance is very, very important as part of our preparedness program. So what are the things that will require for a national IPC program? The human and financial resources are very important. And this includes the formation of a multidisciplinary technical team that is dedicated to surveillance for those diseases with outbreak or pandemic potentials, and also able to monitor the IPC indicators. There's also a need for adequate microbiology and lab capacity if we are going to do proper surveillance. And all this should be in the form of a surveillance strategy. And that surveillance strategy includes clear objectives and methods on how to do the surveillance. We have standardized case definitions for those diseases with outbreak or pandemic potential. We have plans on what to do with the data, how to analyze the data, who this data will be reported to, how we will evaluate the quality of the data, and also how to provide such capacity for surveillance and reporting in the event of a large-scale event. An example is the COVID-19 pandemic. I'll quickly share our experience and some of the ways we did surveillance for COVID-19. So during this pandemic, early in the pandemic, we had piloted an application which we use in doing surveillance for COVID-19. One of the important things I'll say about this application is that it required a health facility IPC program manned by an infection prevention and control team, because it was the infection prevention and control focal person that worked on this app. And the important features of this application is that we're able to do health worker symptom screening and monitoring. We're able to do COVID-19 healthcare worker investigation and generate a report. Within the same app, we're able to do IPC assessments. And the same application was also had access to IPC resources, the guidelines, we loaded them there. So it was a one-stop shop, if you may, for the IPC professionals. And what it did really, we found out that it improved healthcare worker tracking, helped us to identify early and manage health workers that were high risk of contracting COVID-19. And all in all, it improved the efficiency and accuracy with which IPC focal persons were completing their health facility readiness assessment. So these are some of those things that can be put in place as part of the preparedness phase way before an outbreak occurs. And that is the phase where we are now to mainstream this into our national surveillance program. Just to show some of the results that we generated with that app. So we're able to get out for health facilities that were involved, their IPC facility assessment scores. We looked at tracking healthcare workers who were registered. We tracked healthcare worker symptoms and screening for COVID-19. We generated all these reports, and all this fed into how we worked and protected healthcare workers as part of a healthcare worker protection strategy. Also, it helped to look at the trends and how decisions were made and how health workers were supported. We also used that same application to monitor infection prevention and control improvement in those health facilities. So you could see how we tracked waste segregation, waste disposal, cleaning and decontamination. But these are applications, assessments, and tools that can only be developed effectively and made ready for deployment if they were done in time as part of preparedness. But they all will support both IPC monitoring and would also support surveillance. Thank you.
Thank you, Dr. Tochi. That's a very good one. And like I said, she may not be able to take questions, but just to note, if you have any question, put it in the chat box. Find a way of getting across to that. And I will quickly now introduce our second speaker, another public health specialist. She's a consultant, and she's a consultant with the Center for Infection Control and Patient Safety. She's a facilitator, an erudite one, And that's our own Dr. Chioma Ejekam. When you've seen her, she's a doctor, she's a fellow of the College of Physicians, and then she has an MSc as well. So over to you, Dr. Chioma Ejekam. She can take questions, so note your questions. Hello?
Okay, so yes, I hope you can see me and hear me. Yes, Dr. Showande, just let me know if you can see me and you can hear me.
Yes, we can see you.
Okay, great, and you can hear me too. That is more important. All right, so yeah, I have a task of doing a major aspect of scoring down into health care associated infection surveillance from what Dr. Tochi has said, and I tried not to make a lot of assumptions. So I'm just going to quickly run through an outline. Just take your overview of what HAI, I'm using HAI, that's healthcare associated infection surveillance is, the minimum requirements, who will be responsible in doing that at health facilities. And the final thing, the monitoring and evaluation of HAI surveillance at the health facility. Now, I must say something that I needed to spend more time before the 5th, which is kind of where the topic lies, because you must understand what you want to assess and monitor. And what Dr. Tochi has done is kind of give an overview that will be beneficial to boarding IPC specialists who is trying to gain interest, who is already a specialist and all that. But the bulk of what I'm going to be doing today, for those who are health managers, these are things for especially at secondary level or tertiary level facilities, you might want to support your team to develop skills, but the how to do and the doing will only be done by somebody who already knows, established in IPC to some extent. So it is good we know, but the practice will really be those who have already established in IPC. Okay, so as an overview, as I mentioned, healthcare associated infections, they allow me to use HAIs, are infections that occur in association with or related to provision of healthcare. And examples are antimicrobial resistant organisms, bloodstream infections, surgical site infections, urinary tract infections, and any area of infection of interest in the local context, depending on the facility or their focus or in care area. And in recent times, so there's addition of the novel infectious diseases. And as some examples I'll be sharing will be, we're all in the COVID-19 pandemic. So we will see some examples in the COVID-19 pandemic specific focus. And certainly, HIs remain an important patient safety and quality of healthcare delivery issue. And of course, affects outcomes of healthcare. It's associated with morbidity and mortality. It increases healthcare spendings for obvious reasons. When there are healthcare associated infections, like prolonged hospital stays, there are readmissions, and there are costs attached to somebody who is meant to have left today and will have an extra 1 week because of infections during care delivery. And it's also important to know is that the first step that must be taken to be able to assess the magnitude of a disease burden or an infection burden in a particular ward, unit, or a facility. Now, for us not to, again, I said I don't want to make some assumptions, especially for those who are here that are not pure IPT special practitioners. So as in the course of my conversation, when I mention surveillance, I am meaning a systematic method of continuous monitoring of a disease in a population in order to be able to detect changes. So she mentioned you want to see numbers, are they going up or going down? You'll be able to analyze the data, you must disseminate the results timely for you to be able to guide interventions, appropriate interventions, and ultimately is to reduce these infections and improve patient care. So it provides good information to the patient and the clinical team. So it's a cornerstone of infection control. In everything, the ultimate purpose of surveillance is to empower decision makers to lead and manage effectively. And I'm going to, course of everything I'm going to be talking will be centered around this last comment. Now, all surveillance systems, whatever it is, will take these 4 components. If there's anything to pay attention to from now moving on, and the rest of my conversation would be, there must be data collection using standardized case definitions, usually guided by international. In this part of the world, we like WHO because it's often directed by low middle income settings. And of course, where you have specialists, you could adapt, but there are internationally accepted case definitions. So whatever you call malaria or you call, is the same thing in another clime. There must be collation of the data. You must analyze and interpret it, and timely dissemination, very important. So I put this particular definition because it kind of captures the first definition of surveillance, gives you the operational activities, but this one gives you the summary of what must be done for you to say you have surveillance. I highlighted the 4 key points I mentioned here, components. Surveillance is the ongoing systematic collection. First, there must be analysis. Second, there must be interpretation of the data. And it's integrated with timely dissemination. If you get data and information, you don't pass it, it could be still, and by the time you're sharing the information, there's already an epidemic or the havoc is already caused. So what is the ultimate objectives of surveillance? You want to reduce infection rates. You want to establish endemic infection rates. You want to identify outbreaks early when you talk about warning signs. You want to be able to convince medical personnel. People think, especially IPC, is a difficult sell. But a lot of my colleagues, I see them here, I always know that I say, you have to know how to make a business case for yourself. And for us in IPC, it is only your data that's the starting point. You should be able to compare rates and, of course, evaluate control measures. Now, what are the minimum information from surveillance? A lot of this would have been mentioned one or the other during Dr. Tochi's presentation, but I'm happy I didn't make assumptions that was going to be discussed in details. You need to understand this before we go into the to-do of the M&E, which will be about 2 or 3 slides. So the information that your surveillance system must give you is to describe the status of infections associated with healthcare. You want to do, put systems in place to identify when this infection is starting. I might want to be able to do a snapshot. How many people had this infection right now? Okay. You want to be able to identify relevant antimicrobial resistance susceptibility patterns. Okay. Identify the risk populations. Identify potential clusters. There are warning signs before an overt epidemic or pandemic. And again, evaluate the impact of interventions put in place due to the evidence you have in hand. So at the national level, Dr. Tochi mentioned this, and I'm not going to spend time on this slides. For you to have a surveillance program, there must be a clear objective of what they want to achieve. There must be standardized case definition that is guiding the whole country. And we must train from the national to subnational, the teams, make protocols available. She shared the protocols. There must be an agreed way of dictating these HAIs. How do you identify who is in the numerator, the people who have this, when the disease or the pathogen, how do you identify it? And the exposed population, which will be the denominator. How would this data be analyzed? What is the reporting line? Do you, at a health post, if you pick up something like COVID-19 patient, do you report to a DSNO? There must be a reporting line. How do you pass information until it gets to the highest authority nationally? And how do you develop interventions? Again, so what kind of infection data? This last point says provide data to guide development. What kind of data? The data will give you infections that may become epidemic, that are commonly observed in vulnerable populations like neonatal units, that may cause severe outcomes, infections that could cause resistant microorganisms that often occur in invasive procedures, or they may affect health workers. Globally, and particularly in Africa, not just Nigeria, we're having dearth, as in shortage of human workforce, human resource for health. You do not want the few who are available to be infected. And for everything about surveillance, Tochi mentioned it in passing, there are certain factors that must be in place. you must have an engaged leadership, depend from the facility level to the relevant authorities. In this context, you have NCDC at different levels of the state, the national and the state subnational level. You must have the government backup. There has to be dedicated persons who are trained. Somebody is responsible day to day, 9 to 5, or at the national level, somebody must be responsible for IPC. It shouldn't be an adjunct or an additional work to somebody's primary responsibility. There must be financial resources to do them, dedicated budget for IPC. You must have the support, dependable microbiology laboratories, or the capacity, the human resources. You must have records in place. There must be standardized methods agreeable. And the informatics, a system at the very rudimentary level, let's say health facilities in a very rural area, must have at least a medical record that you could collect data and refer to when you're coming for your M&E activities. And you now move to the level where you can enter the data electronically, like where she mentioned, shared the application from NCDC that is built upon the IPCAF tool by WHO. Okay, and I'm going to share a version of that as well. Now, let's come down to the WHO requirement for surveillance at health facilities. We have basically 3 levels of health facilities. We have the primary care level, the secondary and tertiary. If we look at the primary care level, with everything I've said about healthcare so far with HIV surveillance, we know that the team that will be able to do that must be multidisciplinary. And you know, this is not likely applicable in primary care facilities, except in private primary care facilities. We have a couple of them, some of them on the call, that are very high level primary care facilities. They may have specialized care, but in public facilities, primary care is used to tell in the community, very basic level of human resource expertise for health. So it's in assessing HIV surveillance, it's not a compulsory requirement because they may not have. But at the bearers, depending on a focus, what I put on the second line, it's if applicable, especially like in pandemics, you may be able to track outbreaks that affect a community. And I'm going to show examples. A simple example will be in the pandemic that we are currently, where primary care facilities have surveillance for COVID-19, because most people will appear with fever and they will assess their PHCs first. So we had systems in place, especially for the COVID-19, triaging at the COVID-19, triaging, outside triage, where surveillance data for COVID-19 is collected in the triage register. I'm going to show an example of that. But majorly, when you're assessing HIV surveillance, where it is expected to be at the minimum will be at the secondary, most secondary, but definitely tertiary care level facilities. And because we said, Tochi has mentioned that as well, you don't need to reinvent the wheels. So it's expected that it is in an integrated system, okay? So you key into the national or the subnational plan, but definitely adapted to the local context of the health facility, especially where they have expertise, okay? We mentioned the facility-based HIV should be performed to guide IPC interventions. IPC interventions are tailored to evidence generated by your HIV surveillance to be able to detect outbreaks. There are diseases that are peculiar to a community. He's mentioned the high burden areas for Lassa fever in Nigeria. So that kind of, those kind of facilities will have that top on their list, which may not apply in other parts of Nigeria. And the hospital-based infection surveillance system should be linked to integrated public health infection surveillance systems. I've mentioned that. Active HI should be conducted and include information on antimicrobial resistance, which is currently about, with the recent global burden of disease, is topping, I think, number 3 or 4, if I'm not mistaken, but for the first time, hitting as a priority concern globally. And of course, methods, you might choose methods for your HAI surveillance. It could be prevalence, I mentioned earlier. I want to get a snapshot of the number of people who have this disease and who are the people exposed as a denominator, or could be active, which is actually a recommended, where you can get the incidence rates who are coming down with this disease, okay? And certainly, sorry. Can we mute every person outside me? Thank you. So I mentioned enabling structures. We must have a dependable laboratory. You must have medical records available. You must have trained personnel, and you have resources, financial resources to be able to support your surveillance activities. And these methods we've repeated again must be directed by your priorities. So prioritization is an important aspect of having to criteria for AHI surveillance in a facility. You prioritize based on what is prevalent in your facility. It could be surgical site infections for facilities where surgeries obtained, or urinary tract infection, catheter induced, so catheter associated. So a system of surveillance data quality assessment should be in place. We've mentioned that when data is available, there must be a system to assess the quality. And this could be case reports or case notes, medical records where this data is generated from, so that when somebody comes for like medical audits or M&E, they should be able to refer to that. Even when there is a focal person an IPC focal person who generates this data, the person probably feeds back to the IPC team or the IPC community. They should be able to look into that and see when numbers are not tallying, what is happening before it gets to the final part or international community being discussed. So data quality is of essence. And it must be based and supported by medical data and microbiology and laboratory capacity. We've mentioned that. Then regular feedback needs to be provided to key stakeholders. So who is responsible for surveillance at PHC, at health facilities? At the primary or secondary level, you could have an IPC nurse, IPC focal person at primary care level. And the secondary level, you could have an IPC focal person again, or a link nurse at different wards, okay? And to some very specialized primary care facilities, they may have an IPC team, an IPC or an IPC committee. An IPC team, different from committees, that the team is responsible for the day-to-day operational running of the IPC in that facility to ensure people comply with the protocols, the best practices for IPC. And for baseline should involve a doctor and an IPC nurse. But when you use the word IPC committee, they suggest or provide a strategic direction for IPC in the facility. It must be multidisciplinary. You have epidemiologists, you have biostatistician, you have the microbiologists, clinical microbiologists, you have the DSNO of maybe in Nigeria, of the sub-national region, part of the team. So that's the difference between an IPC team and an IPC committee. At the tertiary level, certainly you expect an IPC committee or team. They should have an AHI and AMR surveillance team in place. That is their responsibility to plan and conduct surveillance, establish the linkages with other partners. So now let's get into monitoring and evaluation call. Again, not making assumptions. When we say monitoring, it means an ongoing and planned way of assessing, observing closely the activities are followed. It compares what is happening with what is expected to happen. So most times, somebody monitoring would be somebody who is kind of involved in the process, but not be directly. So if you look at a tertiary facility, every ward will have an IPC link nurse who will probably generate this, do the active monitoring of this HI surveillance. Now, the IPC focal person in that facility, let's say UNTH Enugu, because I know Kachi is here, can do the monitoring. He goes to NNU, goes to surgical ward to now get this data. That becomes IPC focal, okay? So they do monitoring. Now, evaluation would be definitely somebody who is external to the day-to-day running of that facility. In this context, NCDC can be the person that will want to assess what is being done in the process to determine the extent of the services and results, how they're being achieved, and analyze any discrepancies. So they may want to be doing quarterly or biannual kind of evaluation. So for you to evaluate, that means there is an existing monitoring data to be looking at, okay? And we're going to come to that. And for the M&E of HI surveillance, we're going to be using the IPCAF tool. In this, the IPCAF is the Infection Prevention and Control Assessment Framework tool. That's actually the tool that Tochi presented. on that NCDC, their own version made for Nigeria, or the version she shared. But I'm going to be sharing what is important is the key indicators that will generate the output that you saw, okay? And for all those who are in IPC, we know you have the 8 core components of infection prevention and control according to WHO. And everything we're speaking about, HAI surveillance, is actually the core component 4. So if you open the IPCAF tool, especially you will focus on the core component 4 to be able to do HAI surveillance or M&E in any facility. And we've mentioned that IPCAF tool is only applicable and usable in specialized health facility level, so most times secondary and tertiary. However, we have at the primary care level, I mentioned, we have a tool developed by Infection Control Africa Network in support of with results Save Lives, Africa Center for Disease Control, and other partners. They've endorsed this tool. It's a collection of all the different components of core components of IPC that is definitely required and achievable at the primary care level. So I'm going to show you the surveillance part of this particular tool, but IPCAF, and for obvious reasons I've repeated many times, would be most suitable for secondary and tertiary level because of specialized care. That's where you see HAI surveillance programs more active. So the rest of the few slides I'm going to be showing now is to tell you the 15 indicators that we need to focus on when you're that are indicators that assess the healthcare associated infection surveillance on the IPCAF tool. So you see the first question says, and remember I took you through several slides because you must understand what you want to assess. So I'm going to run through this quickly. Is surveillance a defined component of your IPC program? So if it's existing, the response is yes or no, and there's a score to your yes or no. Do you have a personnel responsible? We mentioned there has to be dedicated personnel. Are the professionals responsible for activities trained? We've talked about that. There are resources that must be able to support HI surveillance. Do you have informatics and IT support to conduct the surveillance? Do you go through a prioritization exercise to determine the HAI to be targeted for surveillance? Remember, I've spoken about that. You prioritize based on what is prevalent in your facility. Even because you don't want to, especially when you're starting HAI surveillance, you don't want to be overburdened and dive into like 10 things. You might want to start with SSIs and other things, COVID-19 surveillance. The 6th question says, in your facility, is surveillance conducted for, now bringing in the commonest prioritized areas of focus. But again, for your tool at the level of secondary tertiary, you can adapt this to specific focus for your facility. But these are common ones. So do you regularly evaluate your surveillance in line with current needs and priorities of a facility? You respond yes or no, and you get scores based on your response. Do you use reliable surveillance case definitions? Of course, this comes from the protocols, guidelines that is approved nationally and probably adapted to your health facility. Okay. Do you use standard data? 9 says, do you use standard data collection methods? Is the active method that is used, which is recommended? It is better to have this system that tracks the commencement of these diseases. That way you will know how to actually prevent, rather than always using a point prevalence kind of studies where you're going to just say 20 people have malaria. Why are you not looking at other conditions, other factors or risk factors that increase the possibility of these people coming down with these diseases? Okay, so do you have process in place to regularly review your data quality? Remember, we've spoken about that, to respond accordingly. Do you have adequate microbiology and laboratory capacity to support your surveillance? Based on what you have in your facility laboratory support, you respond accordingly. Are your surveillance data used to make tailored improvements of IPC practices? You respond accordingly. We've spoken about that. Do you analyze antimicrobial drug resistance on a regular basis? You respond. 14 says, do you regularly, for example, quarterly or biannually, to surveillance, feedback your surveillance information? Who do you feedback to? Do you feedback to the nurses or the healthcare workers frontline, to the clinical heads, to the IPC committee, to the managerial administrative level? How do your feedback how do you feedback? Is it written? Do you make presentations to respond accordingly? So these are just the surveillance indicators on the IPCAF tool that we've spoken about. This is a global tool, and you can adapt, especially on the focus prioritized intervention, prioritized disease areas. So I mentioned about a tool that is better adapted for primary care level, okay? And it's in use. We've used that in major projects during the COVID-19, trying to improve IPC capacity in African countries. Especially supported the leading of this project in 8 African countries. Nigeria was one of them. So a lot of the people on this call too are familiar with this tool. So this, you see, it is in context, it is COVID-19 specific, right? And you see this surveillance is trying to check number of patients that are coming to this facility. It is, this data can be filled in from the medical records. Number screened at the entrance of the facility, because we know you are meant to screen every person entering the facility, both patients accompanying patients, healthcare workers daily. So how many of them are suspected? How many of them met the case definition for COVID, suspected COVID? You put in the numbers. How many healthcare workers reported to work in that last month? How many of them were suspected to have the infection, for COVID? How many of them were confirmed? So if you look at these indicators, it tells you how many of your healthcare workers who are coming down with the disease. It means that your surveillance process in that facility is suboptimal. And we're going to see an output that this generates, okay? Okay, again, it goes further. We've mentioned that HI surveillance can never exist in isolation. It will always come under an existing IPC program. No matter how basic the IPC program is, HR surveillance will always happen in an existing IPC program. So you need to know if there are even records existing. For this primary care level, when they're asking about triage forms, do they have guidelines that guide them on IPC practices? Do you have a personnel that is trained? Those things actually make it possible and make it doable to do surveillance, okay? Now, the rest of this is all going to show you a few examples of data presentation. We've spoken that whatever you do not show it doesn't exist. If you don't document, it does not exist, okay? And you must be able to make this presentation feedback in a timely manner and in a stakeholder appropriate format. So this, again, I just blinded the facility, but this is one of our outputs in 2021, where you see the patient screened, okay, in the month of, this is an evaluation output data presentation. In the month of May, you see the color, and in the month of October, how many were reported to the authority? How many healthcare workers are suspected of COVID? How many were confirmed? Your target and improvement plan is to make sure that this number on this number reduces. If you're not doing active surveillance and you're not documenting the output of your surveillance and sharing the information, nobody will know what is happening, okay? Now, this is another one showing you accumulative data. This was just like comparing 4 African countries. Again, you see patients screened, reported to authority, healthcare workers suspected, confirmed, but looking at May, June, July, okay, and a cumulative record for a group of African countries, okay? Of course, this will again guide the support of the funders to actually see the funds that are providing, is it improving IPC practices at facility level, especially in that region of Africa. So I mentioned that everything I've taken from first is not to make assumptions, and I've taken us through each component. We've gone through the indicators. Now, this is a summary of what you will do on the day you get up from your house to want to go do the M&E, okay? So you have agreed that you must have human resource who will do this M&E or assessment of evaluation, either monitoring or evaluation of HI surveillance in the facility. You must have your detailed tool, and in this context, either the IPCAF tool or the IPC primary care facility checklist. You then assess your indicators and you analyze the data and note trends. Because when you do monitoring, there's a scheduled monitoring. You want to do monthly. You are monitoring monthly of the data actively documented by your IPC linked nurse. As the focal person, you monitor monthly, and if someone can evaluate quarterly, remember the trends. You must fix your dates. In IPC, we are not police, we're not fault finders. So you must tell people, I'm coming to your ward today to come and assess your HI surveillance, or I'm coming to your facility today, okay? You must meet the management for entry, okay? Even if they're going to be available, they send somebody who welcomes you and works with you, with your team, even the IPC nurse who is in charge of that unit you're going to be working with. This is important because whatever you see, they see with you. Rather than you coming as an IPC police and you get your data, they might discredit that, they might not agree with what you have observed. But when you work in a team, they are seeing what you're seeing and they work with you to improve. Okay, you do your assessment and it's purely by observation. Everything I've shown you there on the indicators, is there a guideline? Is there a tool? Are you doing prioritization? Must be shown to you where it is done. It is not a response, verbal response. Everything about IPC assessment must be done. You must be shown. Then you provide your feedback to that unit on that day. With that team, because you worked as a team, you now produce an improvement plan, because what do you ultimately want to achieve? Improve patient safety, improve the quality of service delivery. Okay, so this is a typical improvement plan. And what I did is just to crop out the surveillance part. You want to know which gaps did you identify on that day? What actions did you make any recommendation on that day you came? Okay, what do you plan to do? If you evaluate, you want to come in the next 3 months, how do you guide them to improve on the gaps identified and who is responsible? So you don't have to take the comments here, but just look, what I need you to focus is on the variables. And an example, on the day these people screened, they noted that the triaging of patients is still suboptimal. That's the surveillance, where you get the surveillance data. So they discussed this with the person who is in charge, the OIC, officer in charge of the facility, and provided IPC and the IPC focal person. So you need to screen. The planned action is to ensure that they screen every person entering the facility, including healthcare workers, and who is responsible. You can see that. So in timely dissemination of relevant stakeholders, to say who are the common stakeholders you see in this, it's always good to start with who. Like if you're doing a ward, the IPC link nurse should know what you found. She shouldn't be called by the manager or the CMD to say, oh, this is the record we got. Because they work with you as a team, they start with the staff of the unit you probably assessed, monitored, or evaluated. You could be the clinical lead in that unit. It could be the facility management. It could be the Ministry of Health, and in this context, the government, NCDC, other relevant partners. Your funders who are supporting your surveillance are interested in knowing where the money is going. And definitely in the context of like COVID and maybe Lassa, you want to provide timely feedback to the community. Community development committees that be very helpful in improving IPC practices in health facilities, especially at community level. So in conclusion, a major gap in promoting effective surveillance always lies between the production of the data, okay, doing your active surveillance, and converting this data to usable information to be able to guide intervention. So I put in this here that if you do AHI surveillance, it will generate data. And for you to respond in action means data use. And we know that the world is the data economy. Data is the new currency, and the health sector must not be left behind. We know a lot of people right now, the Gen X and Gen Z, nobody wants to do anything again. There's no work, but everywhere across the world, people, they advertise, people are not even looking for work, because the Gen Zs and Gen X, and I don't know the new gen, all of them want to be in their house and do their work. Everybody wants to go into one IT thing, informatics, whatever. So it's all about data. I have, in the last 1 week, we've been discussing it, a couple of friends, 3 children, 5 children, all of them are studying one computer thing, IT, data, software, and all that. And we should not be left behind in healthcare. So thank you for listening, and I hope you saw my face. Any questions? You certainly do not have questions.
That's a nice one. Thank you very much for your time. And I'm sure the audience have noted if they have questions, but I think we should quickly go on to Dr. Onyekachi Ugwa to share with us what improvements he's been able to do at the University of Nigeria Enugu, and then we'll take discussion at the end. Well, our time is far gone. So, Dr. Onyekachi.
Yeah, good day, Dr. Sunday.
Onyekachi, please go on. Yeah, just go on because our time is far gone. You can start talking. Yeah, are you sharing your slide?
I thought he was sharing his slide, I mean.
Okay. So that we can take discussion at the end.
Okay, Onyekachi, do you want me to share your slides? Is that what you said?
Yeah.
Okay, so please hold on while I put in a slide.
Send it back to me.
Wow. That was a beautiful presentation, Dr. Ejekam loaded. And I'm sure everybody will have picked one or two things. But if you need clarification, please note it. We can take the questions at the end of this last presentation. As he's getting ready, because he's just going to upload this. He assumed that you were going to share your screen.
Yeah, so, I did. I thought. Yeah.
You can be talking. You can be talking as we.
Okay, thank you, Dr. Sunday. Thank you. I feel very privileged and humbled to have the same platform with Dr. Tochi and Dr. Chioma, Ejekam. Yeah, it's quite humbling. All right, so we're going to be talking about what we've done so far in University of Nigeria Teaching Hospital in Enugu. I want to say that this NSIC has given us a platform to learn, and I'm privileged to be part of the people said that had finished their diploma course with CICAPS, and it's been very, very interesting one, and I'm looking forward to have more engagements with NSIC. All right, so looking at my case presentation, yeah, we can go on next. It's an improvement IPC practice UNTH Enugu. So this is basically the front view, which is actually going under, is under construction, and this is an area view. Yeah, next, yeah. Next. UNTH is actually a tertiary hospital owned by the federal government of Nigeria. It's located at Ituku, which is in Kano West local government. It's actually, that picture you saw before is actually the new site. The old site was actually built in early 20s, in 20th century, I mean, and became a general hospital in 1960. And in 1970, it became a specialist hospital, and down to 2007 when we moved to this new site we just saw. So it's actually known as the National Cardiothoracic Center for Excellence. It has about 41 departments, 9 schools, and 3 outpost centers. The bed capacity is over 600, and it's actually operating in the biosafety level 3 laboratory design. Next. So like teachers, as if I knew, I'm actually going to do this space presentation using the IPCAF tool, and it has the IPC program, Ipc Guideline, the education and training, the HI surveillance, multimodal strategies, audit and monitoring, workload, staffing and bed occupancy, and the built environment. So this is how we're going to look at what we've done so far. So next, for the IPC programs, Before I finished as we didn't have anything like an IPC program. We didn't have an active IPC. In short, IPC was actually dead. There was not like an IPC before I finished my training. And so what we did afterwards is to begin to institute structures, which was the first thing we were told. So we have an effective IPC committee, we have an IPC team, we have linked nurses. I am the focal person, and the team is made up of nurses, doctors. It's a multidisciplinary team, but I'm just putting on emphasis just for us to know that it has doctors and nurses. We still do not have an allocated budget, and there has been adequate microbial laboratory support for routine day-to-day use. At the moment, due to our advocacy and the management has actually erected a space, a structure for the IPC units. Next. Next slide, yeah. For IPC guidelines, like I said, we didn't have an active IPC, so there's no guideline. But at the moment, we are currently working on guidelines on environmental cleaning, and we have actually adopted the National Hand Hygiene Guideline. Next, please. Yeah, for education and training, yes, I actually trained in the hospital in that facility. We didn't have any form of training on the IPC. So, but after, we can successfully say that we have actually trained clinical and non-clinical staff of the hospitals on IPC measures. We've actually conducted some departmental trainings, though not frequently. Trainings that were also carried out through e-learning through using this the NCDC training templates. We had simulations, we had demonstrations and role plays. We had to do a specific training on the link nurses, and also we had a Zoom training with the ARB Association. Next slide, please. Okay, so this is a picture showing trainings and all the things regarding the training and education. Next slide. And on HI surveillance, before now, we have 3 infection control nurses attached to the microbiology laboratory who are partially trained. Mostly what they do is just to collect data. And like what Dr. Chioma said, it's not just to collect data. What are we doing with the data? And how, are we going to respond to the data? So these are the gaps, like I said, it was a bit dead before now. And so right now, what we are trying to do is to have this infection control nurses queue into the IPC team so that we can have an effective way of, looking at this data and making sure that things go well. Also, we can also say that we have actually keyed into the NCDC MAL surveillance. We have these machines are very good, the Vitec and the Bacteria Alert 3D machines. And we also conduct quality control surveillance, which is of international standard. Next slide. So these are the pictures showing the Vitec compact machine and the Bacteria Alert 3D. These machines, actually what they do is to detect microbial detections for, they're automated, they're quite efficient and user-friendly. Also, real-time results is actually being, so it's very, very handy. Next slide. So looking at the multimodal strategy, we actually had to implement the first one and the permanent one, which is the hand hygiene improvement strategy. So we looked at the system change. I can say that we have presence of water, which runs intermittently. We have the pharmacy department that produces alcohol-based hand rub. We have the sink to patient ratio, which is not adequate in most wards, although most wards supplement with their verenical buckets. There's availability of soap and other hand hygiene materials produced by the pharmacy departments, and we have actually constituted a hand hygiene team. So on education, we have pockets of training, like I mentioned before, and we find ways to create awareness with IPC measure during our pre-employment medical examination. This we do with the community medicine department. So make sure that once people are employed, we run some IPC measures during their when we meet them at the staff clinic. Next slide. Yeah, at evaluation and feedback, we have trained link nurses who are there to monitor hand hygiene practices and to give us feedbacks. Well, we have not done a formal auditing and monitoring of for example, the hand hygiene compliance. We're yet to do that, or we are yet to, like I said, we have not done a formal baseline study. Work mode reminders, we have posters all over the world for awareness. And we also have some audio visuals in most of our clinics and ward, which was actually a good support from the management. In those audio visuals, we have health promotion that we put in them. And actually, we have something we're working on hand hygiene and on 5 moments of hand hygiene. And next slide. Yeah, institutional safety climate. There is actually a visible support from the management through some of our senior staff, and especially doctors, are not observing hand hygiene. The management also supports events related to hand hygiene, like the celebration of the World Hygiene Day. Yeah. Next slide. So this is some of the wards and some of the clinics where we have the hand hygiene station, and you can see that we have our own posters, which is all over there. Yeah, next slide. Yeah, these are the slides shows our World Hand Hygiene celebration for this year. I would say that the hospital actually been so supportive when it comes to this. Last year and this year we had this, and you can see our CMD who was part of us and identified with this course. And that is the hand sanitizer from the production units and the pharmacy department. Next slide. The link nurses, yeah, they're actually being trained, like I said. We've not been able to get something very detailed because we've not yet commenced hand hygiene compliance. We've actually done a pilot so that gave us the inference, but we've not done a hand hygiene compliance yet. So, but we get feedbacks from the IPC doing IPC team physically and virtually, you know, if there are issues in the world, in how people react to, you know, things that have to do with IPC. So, however, I want to say that the WHO self-assessment framework survey has been done, and we do it annually. And at the moment, we're presently at the basic level. Previous year, we're still at the basic level, but I just pray that next year we should actually move up to maybe the intermediate level. Next. Here, and workload, staffing, and bed occupancy, we still maintain the 1 meter space in between beds and the wards. There are also systems to respond to this. You know, whenever the ward is filled up, they scale it up. So they are being adjusted. So there is the design in the ward that corners with international standards regarding bed capacity. The healthcare worker to patient ratio across the facility is slightly ideal. Yeah, because you know, it's a tertiary institution, so we have a good number of staff. Though because of the brain drain, where a lot of people are leaving at the moment. Next slide. Looking at the built environment, yeah, I would say that Enugu is a very peculiar city or town or state. Yeah, because we have scarcity of water, and this is a very big issue. And I would say, yeah, before now, less than 50% of hand hygiene stations were functional. And also we have shortage of materials for cleaning. But after much, you know, after having the IPC structure and advocacy, I can say that, yeah, there's been a serious and tremendous improvement in water service. And we have the rehabilitation of the water bus system, and we have tankers who bring in water to supplement. And you know how big the hospital is, so we're not fully adequate, but we're doing it's at least better. The water we have is actually safe for drinking, and I can actually say that over 75% of these hand hygiene stations are actually functional. And at the moment, we have repairs of toilets, especially at the outpatient clinics, and yeah, natural ventilation is adequate for patients. Next slide. Yeah, this is a very serious concern because we have inadequate waste collection containers in a facility. The presence of single patient room exists. We have private suites. We actually have the isolation center as well. We have presence of incinerator for treatment of waste. And we have presence of dedicated central sterile service department known as the CSSD. Next slide. Okay, so this is the water project that we have that so far, which the CMD has actually done tremendously. The support has been very, very encouraging. And in the first one, level A, we can see this is water from the source, the water board, and it actually it moves down to the tank here, level B, where it's being treated, and down to the overhead. So this is actually at the beginning, at the gates of the hospital, table A. Then it moves down to C, where we have the overhead tank. Then D is where we don't have the piping down to some areas of the hospital. So this project has not actually gone through all the places in the hospital. So this is actually the first phase. And we can have water running down. This is actually the ICU. The picture on E is actually the ICU. So this so far we've gone with the water project in UNTH. Next slide. Yeah, this is the incinerator. We have two. This is one of them, and you can see that the fence work, which is to cordon off the space there, and the injection boxes are there at the clinic. Next slide. This is our isolation center, which is, next slide. Okay, so this is the production unit of the pharmacy department. We produce liquid soap, we produce the hand sanitizers and the bleach so this is actually packaged in a way that every person going on admission goes with the bleach, the sanitizer, and the liquid soap. This has actually been implemented recently, but we started, the pilot was done in the A&E department. And so this is the production of, this is just for environmental cleaning. Next slide. And this was the look, this is something we're doing. This was behind the scene of the 5 moments of hand hygiene we were trying to put out for our audiovisuals for as a local content. So I just decided to throw it in. This is actually in the making. It's not yet done, but I just thought I should put it up here as well. That is me, and that is another doctor, part of our IPC team. Next slide. Okay, so looking at the challenges, we have difficulty, which I think is common to every other facility, maintaining positive behavioral change in health workers. We have delay in the supply chain of this cleaning materials. The bureaucracy is quite much. Yeah, we have issues with wash. We have issues with poor segregation of waste, which is something I am actually taking working on right now, because based on the studies I'm actually working on cleaning and environmental waste management. We also have, we have inactive members, which can be so discouraging sometimes. And I want to also put it out here again that some of our lead nurses have actually, the brain drain is actually affecting that angle as well. And also we have financial constraints because there's no specified budgets for IPC. And in conclusion, I want to say that IPC improvement in UNTH has experienced a reasonable amount of growth. However, all stakeholders have a role to play in ensuring that the quality of healthcare services and patient safety meets global standards. Thank you very much. Next slide.
Thank you. Thank you so very much. That is it. Now we want feedback from the audience, but there's something in the chat box from Dr. Ejekam, for Dr. Ejekam. Can you open the chat box? Can you check this for Dr. Ejekam? She has a comment there, the long one. Oh, somebody's already replying. Dr. Ejekam?
Okay. Yes. I think John asked. I said that Dr. Ejekam, you recommended having staff who are solely responsible for surveillance and not added to other routine responsibilities. How can this be achieved in public healthcare facilities where human resources are often scarce and surveillance performed as an add-on responsibility? And I think that Okwor nicely, told her that this is a standard. It's all a gradual process. We're all work in progress, but I specifically responded to her concern, and she has acknowledged that. I said, Joanne, I didn't mean dedicated staff responsible for HI alone. Remember that we mentioned that HI surveillance the starting point for everything is establishing an IPC program. And if we, from Tochi's to mine and Dr. Kachi nicely, that's very proud of everything he mentioned there. We did a recent visit to his facility, and we're very proud of what he's doing with his team in UNTH. So HI surveillance, when we said dedicated person, it was dedicated person to IPC, okay? And remember I mentioned who is responsible. We talked about at the primary care level, an IPC nurse, or a focal person if that exists. At secondary and tertiary, we expect an IPC team and committee, and I differentiated them. So certainly they are coming from there, they are doing IPC, and they are the people that will have to do the monitoring and evaluation. So I think the response I took time to type, and I think it's clear. That's all from me. Over, Dr. Shawande.
Thank you. Thank you. I hope you are satisfied, but this discussion cannot be finished here because this is an ongoing thing. Dr. Kachi
responded. She's happy.
No,
I said John has she's happy with the clarification.
Okay, very good.
Yes,
as we are discussing, please note that you need to give us your feedback on this session so that we can continue to improve for our record. I want to say that we're really grateful for people that have stayed on till now. It hasn't been easy because some people actually came here, they have problem with the internet, or with either internet or the power supply. So for at least coming this far, we want to thank you very much. But I don't know if anybody has anything hot, you want to put up your hand and ask. Dr. Chioma, Ejekam is still on. And if you have questions for Dr. Tochi or Okwor, we will pass it on to her. The discussion will continue. So anybody that has any thoughts? Anybody? Chineye, I can see you. Hello. Hello, are we all satisfied? Please go to the chat box and do the feedback. The link is there. Do the feedback. Or if you want to type, you can type. we are reading what okay. So please, I can confirm that the link is active. So please click on the link directly, or you can copy and paste it. I'm just going to put only the link now. I'll remove every other information. I'll put only the link so you can copy and paste if you have issues. But I have confirmed that the link works. Thank you. Any other comments, reactions from anybody? Chioma, do you have any comments? You said the presentation from many people. I know it's work in progress. It's not easy. Rome was not built in a day, but we have to start. We must have that will to effect a change. Any comments from anybody else as you are feeling the feedback?
Yes.
Yes.
Okay, so Dr. Shona, I think one comment that I think, okay, you know, because of what I mentioned there, we visited some parts of Nigeria. So a couple of our team members are here, our IPC diploma graduates, and I'm just telling them on what we're doing, but we have avenues to actually share best practices and novel practices, by the way. One of them would be, we know we all have like common rooms. This may not be specific to HI surveillance, but for every, highlighting that IPC program exists, IPC activities are being carried out in the health facility, typically like hand hygiene programs. They're already doing them, and we found them very interesting. You know, common rooms, if you get to hospitals, like common rooms, CMD's offices or ARD rooms, the TV, the way you go to banks and you see them advertising what they do in the banks. So these are teams in their different facilities, put up IPC like reminders, you know, IPC activities, what they're doing, and reminding staff on how to comply with practices. So we found that very interesting, and I just think it could be dropped here. It's actually a very good one we saw. And I see Chineye is raising his hand, so I can pause it, but that's something I found very interesting that we can share in this group. Over.
Thank you very much. At least it's good that something is happening, that we are not on the same spot. Chineye, your hand is up. Chineye? Hello, can you hear? Chineye?
Like it's a legacy hand, according to Prof.
Can you hear me?
Yes, we can hear you. Yes.
Yeah, very good afternoon.
Good afternoon.
Yeah, I've really enjoyed the session. It's been a wonderful one. I wonder why you people decided to put two heavyweights together to present. But it was quite some learning moment. It was quite some learning moment. And we're very grateful. I also want to commend Dr. Kachi for the work going on at UNTH Enugu. It's quite some kudos to him being able to navigate the terrain. I remember when it was like an everyday headache, and it's like I'm not thinking it's but hearing his presentation today, I feel very happy. I feel elated that he's conquering a lot of those initial hiccups. And it's quite some encouragement to everybody who seems to be facing lots and lots of hiccups, that a little persistence and patience with some pragmatic and innovative views and networking and sharing ideas with others will always make you triumph in this IPC. Thank you so very much. I've learned a lot.
Thank you. And this is to say that whatever is done is doable. And we're all in Nigeria. We're all in Nigeria. All you need to do is to keep on pushing, push, and one day you'll be able to, because of progress. We want to thank you all very much. I hope everybody has clicked on the link and given their feedback. And then on that note, I think thank everybody for being part of this session. And to remind you that we are on the last Thursday of every month. So next month, we'll come up with another session. Hopefully that will be very interesting as today. We know we have some hiccups this session, but we thank God that this is happening. When we hope to take on monkeypox and if possible, start and see whether we can get facilitator to come and at least update us on monkeypox. That's the main thing now. We don't have map up here, but we don't, but we know we have Lassa fever that is endemic. But we hope to just bring us another interesting session next month. On that note, if we are all comfortable, I know we've gone 15 minutes above our time, but I think it's worth it. And I want to appreciate you and say thank you all very much, especially to our erudite facilitators. Dr. Chioma Ejekam and Dr. Tochi, Okwor, who is transiting in between time zones. I want to say thank you very much for making time out to come and share your experience and knowledge with us. And I know you're always with us. If you still have concern, and we can always reach you out. Thank you all very much. Thank you. Thank you. Hope to see you next month. Thank you and God bless.
Thank you, Ma. Bye, everybody.
Bye.